Our group is Associated Patient Advocates. We work on behalf of patients. You can see our contact information on the screen below. Should you wish to be added to our email tree for future announcements, since there are people here that I do not personally recognize, and I have no idea how it is you found the announcement. So just email us and we will make sure that we do get you notices in the future. But if not, you can go to our website and expect that we will be doing something on the last Tuesday of every month at 6:30 Pacific time. We hope this works out for everybody. Why did we start Associated Patient Advocates? Because we realized that many people struggle with communication and understanding their physicians, understanding their insurance, dealing with complicated issues when you're not feeling well, people who have family or friends who are not coping well. And there's obviously a need. If things were perfect, there would not be such a need. This particular presentation is part 2 of our presentation on following the money. I enlisted Shireen because she has worked in the money part of the business for many, many years. Next month, we expect on managed. And should you find that Medicare seems complicated after we speak this evening, rest assured, we picked Medicare as an intro after doing a little bit of exploration of healthcare around the world, because believe it or not, that is actually the simplest of the insurance things in terms of carriers to navigate in the United States. It's nationwide, and pretty much every physician, hospital, and provider in the country understands the rules of Medicare. So with that, let me introduce myself. I am Harley Schultz. I was an internal medicine physician, still am, practicing in the San Francisco East Bay for many years. And we try to do for our patients what we hope to do as advocates for our patients, which is to do our best on their behalf. Shireen is a classmate of mine from business school and has worked for many years in both the legal side of the business in terms of legal compliance as well as the money side. And she is the person who will take the lead. And I'm going to turn it over to you, Shireen, to share with us your thoughts.
Great. Thank you very much, Dr. Schultz. I appreciate it. As Dr. Schultz mentioned, my name is Shireen Honest. I currently work for a population health management company, and this company is focused on the wellness of our patients, and they are the senior population, your Medicare Advantage patients whom we serve. As Dr. Schultz mentioned, I have a healthcare MBA as well as a master's in healthcare law. I also have an extensive background in healthcare operations as well as revenue cycle, which is why Dr. Schultz recruited me for this particular presentation. Today's presentation will really be based and targeted to patients and their families, those who are new to Medicare, so some helpful information that they will need as they navigate through the Medicare process, parts A, B, C, and D. And so, hopefully we'll have some helpful tips. There'll be some resources as we go through the presentation at the end. So as Dr. Schultz mentioned, there was our first part 1 webinar, went through the healthcare system and kind of gave a background and history of that. So this is our agenda. We'll talk about how patients become eligible for Medicare and signing up for Medicare, what parts A and B are, who's covered, what's not covered, what's a supplemental insurance, a Medigap plan. We'll run through a day in the life of a visit to your doctor. We'll look at some examples of explanation of benefits, EOBs, and what to look for when you're looking at your own explanation of benefits when you receive it from Medicare. We'll talk about Part D, which is your prescription drug coverage, as well as Part C, which is your Medicare Advantage plan. And we'll go through more detail as we discuss this. So the first webinar that Dr. Schultz presented was an overview of the U.S. healthcare system, but it definitely gave a historical view. It took us back multiple centuries as well as across many different countries, and explained how the healthcare system in general has evolved across different countries across the centuries. Talked about the advent of Medicare, Medicaid, how health maintenance organizations became prominent, as well as Obamacare and several other items. As Dr. Schultz mentioned, these presentations are on the Associated Patient Advocates website, as well as the YouTube site, and it can be found here. The link to it, it will be in the presentation once you receive it. So starting with talking about Medicare and how patients become eligible for Medicare. So typically at age 65 or older, a patient can be eligible for Medicare if they are a U.S. citizen or a permanent resident. If they are under 65, the way they could potentially qualify for Medicare is if they have a qualifying disease that qualifies for Medicare disability. As it says here, for example, renal failure, another disability area that a patient could qualify under Medicare disability if you're under age 65. Now you do have to pay into the Medicare system to qualify for certain benefits. If you or your spouse are getting either Social Security or the retirement board benefits, you're automatically going to be enrolled in Part A and Part B on the first day of the month that you turn 65. So when we talk about, signing up for Medicare and what that means, now Part A, which is what we call the hospital benefit that takes care of your inpatient stay, is considered premium free. So if you or your spouse paid into the Medicare taxes throughout the time that you worked, you will be, once you turn 65, you will be able to automatically enrolled into the hospital benefit, the inpatient benefit, Part A, without having to pay a premium. Part B, which is your outpatient services, and when you go to see the doctor in their office or have some type of lab or some other home health services, and we'll go into more detail shortly on that. Part B, your outpatient services, that premium is paid through your Social Security benefits. You do have to opt in and set up the deduction from your Social Security. So you are, once you turn 65, and we talked about the eligibility criteria in the previous slide, you are eligible for Part B at that point, but you still do have to opt in and set up the deduction from your Social Security. The premium, which is your monthly amount that you have to pay to actually have benefits through any kind of insurance, whether it's health insurance and or it could be prescription drug coverage. The premium amount in 2021 for Medicare Part B, the outpatient service, was $148.50 a month. Now that premium is also based on the net income. So the more money that you have and you make, the higher the premium amount will be.
One point on two things. George, if you could mute yourself. You have to opt in to get Part B. Ideally, they would have the system set up so that you would automatically get Part B and have to opt out, which would be simpler for people. The other is that if you are fortunate enough to have sufficient income to have to pay a higher premium, count your blessings, because in reality, a minority of the expense for Part B is actually paid by premiums. Most of it is paid for by the general taxpayers. So you are actually getting a bargain that is essentially 3/4 paid for by other folks. So continue, Shuri.
Now with Part B, as it is an opt-in product, there could potentially be a late enrollment penalty that you could be assigned if you do not get that Medicare Part B, the outpatient service, when you are first eligible for it. With that late penalty, it could be where your monthly premium can go up by 10% for each of the 12 months that you are or should have been covered under Part B. And each time you pay your premium, so each month, you will be assessed that additional late enrollment penalty fee. And it can definitely go up the longer you are without the Part B. So for every 12 months that a patient could be or does not enroll or opt in to Medicare Part B, that percentage will increase over each of the 12 months preceding. So when we talk about out-of-pocket costs, the out-of-pocket costs are what Medicare assigns as a patient responsibility amount. So this is what Medicare has assigned you as a patient to pay. We talked about premium. So your premium is the monthly amount that you pay to actually get health insurance or prescription coverage. Deductibles are the amount that you pay or the patient pays before the insurance starts paying. Coinsurance is the amount that it's usually a percentage of a benefit amount. So that's the amount also, for example, with Medicare. Medicare has the deductible that the patient has to pay. And here it says your Part B deductible for 2021 was $148.50. Once that deductible is met, then at that point, the Medicare will pay 80% of the allowed amount of the charge that's sent to them from the provider or the facility. Not the facility, excuse me, from the provider. And then the patient's responsible for 20%. So that's their coinsurance amount that the patient's responsible for. And a per diem is this a per day charge. So here are some examples in the table to the right for different premiums. So we talked about Part A premium, Part B premium. So looking at 2021, your Part A premium could be anywhere from $0, which is your premium free, if you or your spouse had paid into the Medicare tax system. And if not, it could go all the way up to $471 for a premium amount, which is a monthly amount that you pay. Part B premium is $148.50 in 2021. And then here for Part A and Part B deductibles, you see Part A deductible, which is the amount that you pay on them at some point in the beginning of the year, typically, before the insurance starts to pay themselves. For Medicare Part A, which is the hospital benefit, you have to pay $1,484 of a deductible before Medicare will start paying, and then $203 for the Part B, which is your outpatient services, before Medicare will start paying. For your Part A hospital coinsurance, and they look at with the hospital coinsurance portion, they look at it per the number of days that you're, the range of days that you have utilized that hospital benefit. So if you have utilized the hospital benefit from whatever point in time, it does not have to be days 1 through 60 consecutively, it could be broken out into different hospitalizations. You would pay a hospital coinsurance of a per diem amount of $0. From 61 to 90 days, we would be paying $371 per day. And from 91 to 150 days in the hospital, you would pay, say, $742 per day. And also the skilled nursing facilities have a per day, once you reach a certain number of days, then you do have a per day cost as well with skilled nursing facilities. Again, it's not that you have to be, for example, in the hospital for 60 days, and then at 61 days, you start paying $371. It could be portioned out into multiple different visits to the hospital.
I would just point out that very few patients, and percentage-wise, have more than 60 days in the hospital in a given year. So the odds are that you will wind up paying, if you are unfortunate enough to be hospitalized, the deductible. Okay, back to you, Sean.
Thank you. So if you're new to Medicare, there are a couple of ways that you can get into the Medicare system. One is through the Part A, which is their hospital benefit, and Part B, the outpatient benefit. Or you can go into the Medicare Advantage Plan, Part C. We have to also take into consideration the prescription drug plan, the Part D. And then there are certain additional plans called supplemental insurance or Medigap plans that help supplement your Medicare Part A and Part B benefits. And we'll talk a little bit more as we go. We'll go into a little bit more detail for each of these areas. Some of the things you do want to know, though, as you are new to Medicare, every year by October 1st, you want to take a look at the benefits that you have enrolled in. And this is the time that you can have an opportunity to change the way that you utilize the Medicare system. So we talked about Medicare Part A and B. We're also going to be talking about Part C, the Medicare Advantage. So this is the time you want to review your health plans, your prescription coverage plans. So October 1st is the time that you want to start looking at that. Between October 15th and 7th, and December 7th, this is a time that Medicare allows you to make changes to the plans that you have selected. So if you have selected your original Medicare Part A and B plan, this is the time you could potentially select to go into a Medicare Advantage plan, or vice versa. Or this would be the time that you could look to changing the different prescription plan that you currently have. Once you make that determination and you select the plans that you want between October 15th and December 7th, which is your open enrollment period, your benefits actually start on January 1st. Now, between January 1st and March 31st, if you're enrolled in a Medicare Advantage plan, you can, during this period, you can choose to go back to the original Medicare plan, which is where you have your Medicare Part A and Part B. So that is only if you are in a Medicare Advantage plan between January 1st and 31st, you can opt to go back to the original Medicare product. So as I mentioned, your Part A is your hospital insurance. That helps you cover your inpatient stays, your skilled nursing facilities, hospice care, and some home health services. Now, there is some overlapping when we talk about the Medicare Part B, and that's really in the home health service area. So Part B is your outpatient or your medical insurance, which helps you cover your visit with the doctor when you go to your primary care or a specialist visit. So any outpatient care, labs, radiology services that you go to your diagnostic centers to obtain. Durable medical equipment. So if you need crutches, a wheelchair, walker, hospital beds, any other equipment are covered under the Part B benefit. And then there are many preventative services as well, screenings, vaccines, other shots, and other things that are considered wellness visits. And this next slide, I'm going to ask Dr. Schultz to provide some information about the preventative services.
Okay, so Medicare was designed as a sickness plan in 1964 based on what at that time was a pretty standard Blue Cross Blue Shield plan. It did not cover preventive services. As a matter of fact, Medicare once audited me and accused me of doing preventive care, which of course at the time we were horrified to even contemplate. Medicare has since evolved over the years to pay for a variety of preventive services. The big ones are cancer screening that you will see there, patient education, particularly for diabetes, weight management, and heart disease. It also pays for certain vaccines and their administration, specifically influenza vaccine, as well as pneumonia vaccine. Both of these are recommended for everybody over 65. It pays for a thing called a wellness visit, which is an annual visit to your doctor to go over your healthcare needs and wants, specifically the medications you're taking, any interim events and changes in your condition, your medications, your allergies, and to update your general status and see what you need. It pays for a monthly check-in. So if you have 2 or more chronic conditions, and these are widely defined. So for instance, if you have a heart problem and diabetes, you qualify for chronic care management. That means that with an agreement that you will sign, if you choose, the doctor will check in with you, usually via phone, once a month, to see how you're doing. Is there anything you need? And it could be more often, and you have access to that. In addition, once you enroll in Medicare, you are entitled to 1 initial preventive physical exam. That is the only quote, routine physical exam that Medicare pays for, that's typically done when you turn 65. What most patients consider a yearly physical exam, we used to call a comprehensive evaluation. Those are typically not covered unless you have a medical diagnosis. The reality is that most individuals over 65 who are not marathon runners will have medical diagnoses to justify the service. These are in the Medicare website, so you need not take notes. They are very well defined. Most offices understand what's involved. Back to you, Shireen.
Thank you, Dr. Schultz. So we've covered what Medicare actually covers. These are some of the areas that are not covered by Part A or Part B. And this is probably consistent with many of the other health plans out there as well. Typically, health plans will not cover cosmetic surgeries, dentures. They won't cover prescription glasses. You typically have a separate benefit or plan that will cover prescription glasses. Now, they will cover the eye exams because those are considered medical services, but for actually getting the glasses themselves, they do not cover that. Massage therapy, some long-term, now we talk long-term care, and this is really custodial care or nursing home type care that may not be a covered benefit for Part A and Part B. However, there was a previous presentation by Associated Patient Advocates on how to pick a care facility for your mom and pop, which really gave some fabulous information regarding long-term care and selecting a potential nursing home or skilled nursing facility for your patients. So, excuse me, for your family. So that presentation is also on the website. So please look into that as well. But there are, other services like concierge type services that are typically not covered by Medicare Part A and Part B, as well as many of the other insurances that are out there. So I previously mentioned supplemental coverage or Medigap coverage, and this is this type of coverage is provided by private insurance companies. They are not, and you are not obligated to purchase this Medigap plan. You can, as I mentioned, right, typically you will have out of pocket every year your deductible amount, which is the amount you have to pay prior to the insurance Medicare starting to pay. After that, Medicare covers 80%, and then the patient's responsible for 20%. So Medigap or supplemental insurance plans can cover this 20%. There are a few plans as well that will cover the deductible. However, as of January 1st of 2020, if a new patient has come in and enrolled in Medicare, Medigap plans are no longer allowed to cover the deductible amount. So if you have or were enrolled in Medicare prior to January 1st of 2020, then you can have that plan, that Medigap plan that covers the deductible. So for example, my mother, she's 83. She has regular original Medicare, so Part A and Part B, and she has a Medigap plan through AARP that will pay for her deductible as well as the 20%. So typically when she goes in for a covered service on an outpatient basis, and of course if she had to go inpatient, that Medigap plan will cover any amount that Medicare is considered the patient responsibility amount. Medigap, so as I mentioned, helps to pay for deductibles, co-payments, co-insurance is at 80-20%, that 20% that the patient's responsible for. To be able to have a Medigap plan, you do have to be enrolled in Part A and Part B. But please keep in mind, just as I mentioned before, every October 1st, you want to relook at all the different policies you have. You do want to relook at the Medigap policy that you have purchased, because you could be paying the same amount you could be paying different amounts for the exact same coverage for different from different Medigap plans. So you want to make sure that you're getting the best value for the coverage that is provided. And the best time to really buy a Medigap policy is typically when you are in that first 6 months of the Medigap open enrollment, which begins that first day of the month that you turn 65. And again, please keep in mind, you do have to be enrolled in Part B to be eligible for that. Now, federal law doesn't require that Medigap plans sell the coverage if you are under 65. So you may not be able to get a Medigap plan and coverage, but it will also depend on what state you're in, because there are some states that do require the Medigap plans to provide coverage if you are under 65. So that would potentially be for your Medicare disability products, which are typically, if you're under 65, that's how you would potentially qualify for Medicare, is if you have a qualifying diagnosis that's considered a disability. So you definitely want to check with each of your state's health insurance assistance programs or a state insurance department to determine whether or not your state will allow or not allow Medigap plans to sell a product to you if you're under age 65. And we do have some information in the appendix for you to take a look at, some resources that we'll look at the end. So with supplemental coverage, these are the standardized plans that are out there. So A through N with a few letters in between that are missed, but these are the different products and plans that Medigap allows. So Medigap, again, as I mentioned, it can be, if it's sold to new people who have come into the Medicare program between prior or after January 1st of 2020. Unfortunately, the Medigap plans are not allowed to actually cover or sell the deductible plans. Okay, so the plans that cover the deductibles, so for example, here, if you look at across this Medicare Part B, Plan C covers the Medicare Part B deductible, as well as this Plan F. So any new enrollees after January 1st of 2020 would not be eligible to have either Plan C or Plan F. But you can look at the different types of coverage that Medigap plan covers, because not everything is covered. As you can see here in Plan A, the skilled nursing facility, the coinsurance amounts that you would have to pay, there is no coverage with the Medigap plan, right? So most of these coverages are set at 100%. However, again, depending on what plan you have, again, for the skilled nursing facility coinsurance, they'll pay under Plan K right here, they'll pay 50% of whatever that coinsurance is. So you really have to take a look at the different benefits that you have and how much you'll be having to pay out of pocket. Patients who are healthier and will have, less visits to the hospital or outpatient services, may consider different plans compared to patients who may have chronic illnesses that may need additional care and services. And then these two asterisk plans, Plan F and G, are considered high deductible plans where the patient has to pay a large amount. So in 2020, it was $2,340. So the patient has to pay out of pocket $2,340 of covered Medicare services before the Medigap plan starts to pay. Again, this may be an option for patients who are, who don't have chronic illnesses where they have to be seen on a frequent, regular basis. But, definitely options to take a look at as additional, as well as, how much is covered in each of the different areas and the benefit areas here. So you have to consider your Medicare Part A coinsurances, your Medicare Part B coinsurance amounts, how much are they going to cover for hospice care? Here you can see for hospice care under K, they'll pay 50% of the coinsurance or copayment amount, or 75% under the Medigap plan L.
A couple of quick points. This alphabet soup was developed by the federal government so that a Plan C from one carrier is the same as a Plan C in terms of the benefits from another carrier. The premiums may be different, but a Part C from Blue Shield will have the same components as a Part C from United, as a Part C from Humana, et cetera, et cetera. The differences are between the alphabet soup. And you are not obligated to buy any of these. If you are betting that you are not going to need medical care, you can put the money in the bank and just pay the 20% as you need to access healthcare. That's a bet that you will make. If you're betting that you may be ill you are well advised, if you can afford it, to get supplemental coverage. These typically cost something like $100 to $250 a month, depending on the plan you select, the company you select, and it does pay to go shop. Back to you, Sharon.
Thank you. So another thing that you need to be aware of is what we call Medicare as a secondary payer. Now, with Medicare, just like Medicaid, Medicare wants to always be what they call the payer of last resort. So if there is another payer or another reason that they would not be the insurance to pay first, they want to make sure that they are they're looking at all the different benefits and reasons that a patient may not bill, or where a provider may not bill Medicare first. And some of those reasons are because, you know, you or your spouse may still be working. So you could be working age 65. You could be a workers' comp issue. So, you know, if you had an injury while you were still working, you still may have workers' comp benefits for a certain disease or diagnosis that, well, Medicare realizes there is a workers' comp that should be paying first. The Medicare will require that that workers' comp be billed prior to any bills being sent to Medicare. It could also be an automobile accident, right? There could be, so a motor vehicle accident. So there's MedPay. So MedPay is where you select, when you select your car insurance, you select a benefit where if you are in an accident, there you could potentially receive, if you are injured, you could potentially receive some reimbursement back from your car insurance because you choose to have what they call a MedPay. So if you're in a car accident, you're injured, you go and see a provider, you can then have reimbursement from that. So if there's MedPay involved, then Medicare would be the secondary payer. And definitely if there are attorney liens and if there's like no fault types of accidents, Medicare would want, you know, the other product or other, in this instance, the other car insurance through the attorney lien to be first prior to Medicare coming in and kicking in to pay a benefit. So now we're going to just run a typical visit to your doctor. So let's say, you know, you're not feeling well, you call your primary care doctor, you get an appointment to go in and see that primary care doctor tomorrow. So it's tomorrow, you arrive at that doctor's office and you're asked to come, when you go up to the front desk, they ask you to verify all of your information, right? They want to make sure your name and your address, your date of birth, your phone number, your insurance information is all up to date. Right, they may ask you for a copy of your insurance cards and an ID. Typically, this is definitely done at least once a year. And depending on what state you're in or what you know, issues that provider may have had with billing, you know, they may ask for it more frequently. It'll be up to that provider's that different office's policy. So you've checked in, right? You're called back to the back of the where the exam room is. You have your vitals taken, so they take your height, weight, blood pressure, your temperature. You're asked why you're going to be seen by the doctor, right? Or a provider. So you have a variety of different providers. You have your MDs, your DOs, nurse practitioners, physician assistants. So we'll call them all in general a provider. You see the provider, and that provider documents your visit, right? And they determine what services that you receive. Now, these are the services that get billed to insurance. So for example, Medicare, right? And typically approximately 30 days or so after the doctor has billed that visit to Medicare, about 30 days later, you get an explanation of benefits for Medicare. So this is an example of, and we'll go through several examples of how to read an explanation of benefits. So this is an explanation of benefits for an office visit. So this patient on April 19th saw Dr. Zhu. Dr. Zhu spent about 20 to 29 minutes, and this is for what we call a level 3 office visit. This 99213 is a CPT code, a current procedural terminology code, and this designates this type of service that this provider has given to you. It gives you the level of service, about how much time they spent, you know, the amount of medical decision making. So there are several factors that are assigned when a code is selected by a provider. Now, Dr. Zhu on April 19th for this 99213 level 3 visit billed Medicare for $185. Medicare's allowed amount or approved amount is $108.42. Of that $108.42, Medicare actually paid $46.91. So things that are important for you as a patient is to look to see how much you're going to be potentially billed, right? So here it says you may potentially be billed $61.51. So the $61.51 plus the $46.91 is your $108.42. The other important things to always look at are the notes. Okay, so there's a note A and a note B. So a note A here says that $49.78 of what Medicare approved or the allowed amount was applied towards your deductible. So that's the part, the note A, and then the note B lets you know that Medicare will automatically send this claim forward to the Medigap provider, which in this case is United Health Group, so that your provider doesn't have to bill anything, you don't have to do anything. Medicare, after they have processed a claim, if they know that you have, let's say, a Medigap plan like my mother, AARP, they will automatically forward that claim or that bill to AARP electronically so that no one has to do any additional paperwork. So now AARP is going to, or in this case, excuse me, United Health Group is going to receive that EOB. So here we are. We're looking at another visit. So I've changed the explanation of benefits. And this one here is an office visit with procedures attached. And I'll be able to demonstrate what it looks like when the Medigap plan is billed when we move to the next one. So here on April 30th, this patient went and saw Dr. Taylor, who's a podiatrist. Dr. Taylor billed a level 5, this 99215 procedure code, CPT code. He spent more time with the patient. It may have been, and this is also a specialist, it may have been a more complex visit. In addition, Dr. Taylor did 2 different procedures on the patient, a nail plate, some type of separation. So a minor surgical outpatient type of surgery, procedure rather. Now for this 99215 office visit, Dr. Taylor billed Medicare $232.12. Medicare approved and allowed $201.84. And Medicare paid 80% of that, which is $161.84, which leaves that 20% of $40.37 to the patient's responsibility. That is the same as if you look through the 2 different procedures here. So we'll look at in totality for this particular visit for all 3 codes that were billed to Medicare. Medicare allowed, Dr. Taylor billed Medicare $438.51, where Medicare approved $381.31. They paid 80% of that, which is $305.74, and the patient's 20%. Patient responsibility is $76.27. Now, again, we can look at take a look at the notes that are there. And note A talks about this claim shows a quality reporting program adjustment. So a quality reporting program adjustment is, there are certain quality reporting that Medicare requires all providers to submit. If a provider does not submit, they can get penalized on their end, a certain percentage, about 2%, for their services if they do not submit these quality reporting program identifiers. So this is telling you that Dr. Taylor looks like hasn't submitted the certain qualifying codes to Medicare. So he's probably getting some type of penalty on his end where his reimbursement may be a little less than what it normally would be. And then your note B lets you know that Medicare has gone ahead and forwarded this claim over to the Medigap plan, which is United Health Group. So this is now the EOB, explanation of benefits from United Health Group, where we can see here's Dr. Taylor. Here are the charges for that April 30th visit, right? There were 3 different charges. $438 was billed. Medicare allowed $381.31, where they paid $305.04. And then here is the 20% that the patient was responsible for according to Medicare, but with that Medigap plan, Medigap has gone ahead and paid that $76.27. So this is where, when you have that Medigap plan, if there's that 20% that's associated, again, you can opt in. You don't have to opt in, depending again how well or not well a patient is. They could choose to get a Medigap plan. Sometimes it's very beneficial. So in this particular instance, Medigap went ahead and covered this $76.27. And Dr. Schultz, I think you're going to have the next 3 slides. Just let me know when you want me to forward them.
Oh, joy, this is perfect. Okay. All right. So for those of you who have ever seen a hospital bill, this is an example of their retail prices. You will notice a couple of things. Number one, they have a lot of digits in there. These are very high prices. For instance, the top line essentially is a monitored bed with a cardiac monitor. That is for one night, that's about $7,000. You may ask how they arrive at these charges, and the answer is I have no idea. However, this is an example of what they call a charge master. If you see nurses running around the hospital with little barcoded sticky tabs that they take off IV bottles or Band-Aid packages or whatever and stick to their uniform so they can plop them somewhere so they'll be scanned in, so the hospital does not miss a charge for a single Band-Aid. This is what happens. All of these miscellaneous charges get dumped into the hospital's billing department, which then generates a bill. We will show you an example of that. These charge masters can run hundreds of pages of very dense print. So unless you are a combination of a rocket scientist, forensic accountant, and healthcare economist, even though supposedly you can compare hospitals by their charges, this is not an exercise for the faint of heart. Number 2 is, unless you know exactly what's going to be done to you in a hospital, which takes a lot of foresight, it really doesn't matter. What this does, however, is allow the hospital to submit a charge to Medicare for the entire retail benefit that they will try to collect, and to private insurers. The reality is most large private insurers negotiate discounts from these prices. Medicare pays differently. We'll talk about that. The person who is most likely to get the immense bill for the full charge is the poor person who has no insurance. They have no negotiating power at all. If the bill is $100,000, they will be billed $100,000 just for kicks. I pulled up the charge master for Kaiser. These are public domain. I believe a tonsillectomy was $17,000. A gallbladder removal was $32,000. That is without any of the extras attached. Moving right along, next slide. Now, the hospital also has a separate charge master for drugs. So every time you are given a pill in the hospital, you will be charged an amount. Now, it helps if you're a pharmacist, but for those of us who are familiar with a couple of these, amoxicillin, 500 milligram capsules, they bill $15 a capsule. 30 amoxicillin tablets at your local pharmacy is probably $3 to $5. So these also are charges that are not based in anything resembling reality. Next slide. So instead of paying by the Band-Aid, the retail prices Medicare decided that they are not going to play that game. And so what happens now is the hospital submits their retail charges, but they also submit the diagnoses to justify those charges. So say you're admitted for congestive heart failure, pneumonia, maybe COVID, you're 68 years old, you're a woman, and they perhaps put in an IV or this or that. All of that goes into the hopper. Medicare will then make an adjustment and they will pay by the diagnosis. They don't care if you stay there 1 day or 1 month. They will pay what they choose to pay. They have an army of actuaries somewhere who actually evaluates the relative value of these various services. And depending on how they are weighted, you'll see that a liver transplant is weighted at more than perhaps an admission for high blood pressure, which you would think, just based on your intuition, would be appropriate. So we'll see that when we get to an example of a hospital bill and how Medicare chose to handle it. It also explains why the hospitals are in an awful rush to get you, the patient, the heck out of the hospital, because if they get the same amount of money, whether you stay 2 days or 15 days, they're going to want you out in 2 days. They're saving on their cost at their end. It will also explain why they will try to shift a lot of the procedures that you might want. Say you might be told that you should get a mammogram. They will want that to be done outpatient, or they will have perhaps IV medications that are given to you after you're homebound. You go home and the visiting nurse comes out to do that because this is no longer part of the hospital's expense. And hospitals are very good at generating charges and also very good at trying to avoid expense. Next slide. Okay, Shireen.
Okay, so this is a sample of that hospital explanation of benefits that Dr. Schultz was just mentioning. So here you see that it is Part A hospital insurance. This patient went into the hospital on between March 20th and March 29th. It says here, and this is the front-facing piece of the explanation of benefits, it tells that patient right away, you may be billed for $1,484. Now, if you recall from several slides back, that's the deductible amount that for your Part A inpatient hospitalization stay. $1,484 is a deductible amount. All right, so it says here, Part A deductible, you have now met your $1,484 deductible amount for the inpatient hospitalization that began on March 21st. Now, for the 8 days that this patient was in the hospital, you can see here that there are 0 non-covered charges, which means Medicare covered this entire stay. Medicare paid $10,594.57 and applied $1,484 to the patient's deductible. So again, you can look at your notes down here and it tells you here's the $1,484 that was applied to the deductible and that Medicare paid the claim for $10,594.57. And they are going ahead and forwarding this information over to the Medigap plan, United Health Group, United Healthcare, to pay for any, if that plan covers deductibles, to pay for this potential $1,484 deductible amount. So this is that same claim, okay? And you can see here now, it is itemized. So whereas before, when you looked at it from Medicare, it just says that there were 8 days that were involved. It doesn't tell you how much the bill was. But here, when you look at this itemized statement from the Medigap plan, it lets you know for those 8 days, the hospital billed Medicare $114,000. Okay, now Medicare said 12,000 of those dollars were not covered, so charges not covered. As you can look down this row, this column here, there's $12,816 that were not covered. Now here, if there was deductible that they processed or co-insurance amounts, you'd see it listed here. But here's where it says payable, that $1,484 that we talked about previously here, that's the patient responsibility. They are saying that they will go ahead and cover that. So payable by Empire, which is this particular plan, they will go ahead and pay this $1,484. So this is that Medigap plan for that hospitalization where Medicare applied that amount to the deductible.
So just to chip in,
Yep.
Medicare was billed, or the hospital billed $114,000. If you were uninsured, they would try to collect from you $114,000. $8,000 a night approximately is just the room charge for being in a room in a bed in a hospital. However, Medicare said, based on the diagnoses, we do not care what you charge. We're going to pay you the $10,000 whatever, because that is what this particular episode of illness with the diagnoses that the hospital submitted is worth to Medicare. And essentially, this patient had an out-of-pocket cost of $0 for this hospitalization. Rolling right along.
So with your prescription now, we're going to move from, we've talked about your Part A, which is your hospitalization benefit with Medicare. We've talked about Part B, the outpatient service. We're going to now talk about your prescription drug coverage. Now, there are two ways, again, to get prescription drug coverage. One is you have to select that prescription drug coverage. If you have Medicare Part A and B, you add it on, and that's considered Part D, as in David. So you have to have your original Medicare Part A and B, and then you will select a private insurance that will then cover that prescription drug coverage. So, for example, with my mother, she has the original Medicare Part A and B, and then for her prescription drug coverage, I have gone into Medicare.gov, and they have a really great tool that allows you to put in all your prescriptions, put in the dosage, the frequency that you're taking those prescriptions, and it will then allow you to compare different plans to make sure, one, that it is on the formulary. So a particular drug, a formulary is the list of drugs that a particular insurance will cover. So you want to make sure that that drug is covered, that you're taking. You also then want to look at how much you will have to pay out of pocket yourself, right? So you have to consider, one, your premium amount that you have to pay for that particular plan. So we have to consider, I have to look at, all the drugs that my mother takes. She has now Humana, prescription drug coverage, Part D through Humana. I look to see how much her premium is, and I also look to see how much she has to pay out of pocket for each of the drugs. And I calculate to see if that makes sense. And I can compare multiple plans through Medicare.gov and look to make sure that whatever plan that I select for her will, one, cover all of her medications, and also, provide the best value, right? Because each plan can charge you different amounts for the same type of coverage. So you want to just make sure that, you calculate out every single medication and compare it over multiple plans that are available to you. You also want to make sure that whatever pharmacy that you're going to is covered by that particular plan, because not every single pharmacy is going to be on that particular network. So network of pharmacies that are covered by that Part D prescription drug plan. Now, another way that you can get prescription coverage is if you have Medicare Advantage, the Part C. So Part C includes all of your outpatient services, all of your inpatient services, as well as your Part D, your prescription drug coverage. So typically your Medicare Advantage plans will include and encompass all of those different benefits for you. Again, just a quick reminder, the dates that we had on that previous table. You want to start looking at around October 1st at all the different health plan options and benefits that are available to you, both in the regular Medicare Part B and Part C, as well as Part D. And then, make sure that you compare your current plans with plans that are available. Look to see how much you're going to be paying out of pocket for each of the plans, whether it's your health side or your prescription side. look at the premium amount that you have to pay on a monthly basis, as well as any kind of copay or co-insurance amounts that you would be responsible for. And definitely make sure that whatever prescription drug coverage plan you are selecting is in network with the pharmacy that you typically use. These are, again, the same dates that we just mentioned. So we touched base a little bit about all of these here. So how much do you have to pay when you look at a prescription drug coverage? Again, consider the premium amount you have to pay, any deductibles or co-pays or co-insurances. Make sure that your drugs are all covered on that formulary, that drug list that prescription drug coverage plan has available. And you want to be also cognizant of the different tiers, the drug tiers that are available. So there you will pay a different amount, let's say for a copay amount, if it's a brand name drug versus a generic drug, or if it's a new drug that has just been released versus a drug that's been established and around for a long time. So Dr. Schultz mentioned amoxicillin previously. So that's an antibiotic. So that's been around for a very long time. That's an established drug. It's a generic, but there are many newer antibiotics available out there. So you would then, if you chose, or if the provider wrote a prescription for a newer drug or brand name drug, you can anticipate having to pay a higher amount. So here are the different tiers, okay? So if you're in a tier 1, which is a generic plan, this is the least expensive out of pocket that you would have to pay. It typically covers all generic drugs and maybe a few of the brand name drugs. Your tier 2 preferred plan will cover, again, you'll have, instead of maybe a $5 copay, you may have a $10 copay for each of the drugs that are on there. But it covers your brand name drugs that have to be proven most effective for that particular class of drug. So for example, if it's an antibiotic, again, that's a brand name antibiotic, it has to be the most effective that is within that particular class of drugs to be covered under the preferred tier 2. Now, tier 3 is when it's not a preferred plan, and this is where the drugs are considered not to be preferred, so they can be brand names, but that are not considered to be the most effective in that particular class of drug. So you're going to be paying, instead of $10 here, you may be paying $30 for that one particular drug that's considered not preferred. It's a brand name drug, and it does not hit the list of most effective in the class of drug. And then your tier 4 is your specialty drugs. Now these are, as it says, the most expensive that are out there, because these are classified as one brand name, but these are very, very highly specialized drugs, and they are not in any type of preferred class. Dr. Schultz, do you have any additional insight on the tiers on the prescription?
Yeah. So the generic drugs, you may have an obligation to pay whatever it is. It is entirely possible that you could buy this retail because some of the pharmacies, Target has been one of them, has now been taken over by CVS. Costco would be another. Some of the pharmacies have a list of $5 prescriptions. It's $5 for 30 days, $10 for 90 days. These are generic drugs. They tend to be common, very effective, very established. It may be cheaper for you to go and just pay the $10 at your local pharmacy than to go through your insurer. The very expensive drugs tend to be specialty drugs, cancer drugs that are relatively new, special drugs for things like rheumatoid diseases. These are the ones you will see advertised on television because A, they're very expensive, and B, that's typically where the pharmaceutical companies make the most money. So if you see a drug advertised on TV, the odds are it is not a generic, inexpensive medication. So when they say, ask your doctor, that's what they're doing. Next.
Now, this is an example, and Dr. Schultz, I know that you're familiar with this as well, but we're only showing this to demonstrate how complicated some of the the cost sharing for your out-of-pocket and your drug benefit plans are. So we're not going to look through the details of this unless Dr. Schultz, you have some insight that you want to kind of discuss on this example, but
No, just remember that this is publicly available knowledge. You can get this from what is called the State Health Insurance Program in California is called HICAP, Health Insurance Counseling and Advocacy Program. They have this information, they advise people. This is just for your information to see really that even though Medicare in some ways is simple, it's not always that simple. Next.
Now, this is a quick example and sample of an explanation of benefits from a prescription drug coverage. So excuse me if I pronounce the medication incorrectly, but the propafenone.
Very good.
Oh, okay, thank you. I appreciate that. So this particular prescription was filled on March 8th of 2020. There were 180 pills that were provided, so capsules that were provided. And when it was run through the prescription drug coverage, the Part D plan, the patient paid $397.97. And the health insurance, the Part D prescription drug plan paid $596.96. So definitely not an inexpensive prescription. This would probably have fallen into maybe the tier 3 or 4 category that we previously discussed here, either the non-preferred or a very specialized medication. We're now going to move into your Medicare Advantage, your Part C plan. So your Medicare Advantage, Part C, these private health insurances contract directly with CMS, your Centers for Medicare and Medicaid Services, which manages the Medicare insurance. These plans can be offered, again, like these private insurances, through health maintenance organizations, your HMO insurances. They could also be provided through PPO plans, as well as their special needs plans. So special needs plans are designed for patients who have certain chronic diseases that the health insurance plan wants to really help manage these chronic diseases. So there are also special needs plans that are offered by Medicare Advantage plans. So if you're enrolled in a Medicare Advantage plan, what you need to know is that most of the services are covered through the Medicare Advantage plan. They're not covered through regular Medicare. So once you have enrolled into a Medicare Advantage plan, you no longer want to or will use that red, white, and blue Medicare card that you received when you if you had original Medicare. You will use the insurance card that comes from that Medicare Advantage plan. So for example, if Humana is a Medicare Advantage plan in your area, you'll receive an insurance card directly from directly from Humana. So the Medicare Advantage plans, the services that Medicare aren't paid for by the original Medicare could potentially be covered by your Medicare Advantage. And the Medicare Advantage also provides prescription drug coverage. So Medicare Advantage, in essence, takes care of your Part A hospital benefit, your Part B outpatient benefit, and usually your Part D, your prescription plan. So the Medicare Advantage Part C kind of bundles all of that together. So typically you will have a small premium or no premium at all. So premium, again, is that monthly amount that you pay each month to have health insurance. Having no monthly premium, it really depends on the state that you live in. So, for example, in Nevada, because the competition with the Medicare Advantage plans here in Nevada are so extensive, there are no premiums that are paid. Some areas, they may charge a small amount for a premium. You have copays for office visits, and typically your copays in a Medicare Advantage plan or compared to what you would pay in an original Medicare plan for the coinsurance amount are smaller. With a Medicare Advantage, you typically have to be assigned to or select a primary care physician, and that primary care physician will manage all of your care. So they will make sure that you get any kind of referrals to a specialist that you may need. You also want to make sure that whatever doctors that you're going to are in network. So in-network means that that doctor that you're being referred to or that you're seeing even on the primary care side have a contract with that Medicare Advantage plan. So you always want to make sure that you're looking at and making sure that you're seeing someone that's in-network, because if you are not, typically a Medicare Advantage plan will not cover out-of-network services unless it's an emergency. So if you're out of network, let's say you are going on vacation somewhere and you need to, something happens and you have an emergent or urgent visit, they may pay for that emergency room or admission to the hospital. So it has to be some kind of emergency for them to pay an out-of-network plan, or excuse me, an out-of-network service. It also may cover out-of-network if you have renal failure and you have renal dialysis. That's another item that they will cover out-of-network. But you have to really make sure they're definitely sticklers on this. You want to make sure that you're seeing an in-network provider for that Medicare Advantage plan. The Medicare Advantage also requires that prior authorizations are obtained for certain services. So if you have diagnostic testing, you have to go to a specialist. Things that are more expensive will require prior authorization. And that's going to be different across the different plans that there are. So some plans may, let's say, for example, require you to get a prior authorization for an MRI for a certain diagnosis. Whereas another plan may say, oh, if that patient has this certain diagnosis, we know that they need an MRI. We're going to go ahead and let that provider go ahead and order that service, and no prior authorization is necessary. However, what they will do is they will look back and audit and make sure that that service really was medically necessary. And so they will definitely audit and make sure that the MRI was required. But that's done after the fact. And most of these Medicare Advantage plans also have some extra benefits. They may pay for the gym. They may have, so your monthly membership to the gym may be covered. They have, vision and hearing and dental. And we touched base on that when we talked about some of the services that aren't covered by Medicare, the original Medicare Part A and B. But the Medicare Advantage, the Part C, may have that benefit available as extra benefits, not your standard benefit, but these are just some extra benefits. They may have care management services. So for your chronically ill patients, if there are services, or if there are patients who require additional assistance, they may have a care management nurse help the patient, let's say, transition from the hospital, make sure that once that patient is at home, they receive all the services they need. If they need transportation because they need to go and have a follow-up visit with a doctor or have additional testing done from that after they've been discharged from the hospital, that care manager or that care management nurse will help facilitate to make sure the appointments are scheduled. The patient has the necessary medications at home, that the home health services have been assigned. So care management really helps to really manage that care for chronic illnesses after being discharged from hospital. So those are some of the additional benefits that are also available in the Medicare Advantage products. And this is a quick side-by-side of your original Medicare Part A and B versus your Medicare Advantage, which is in the right-hand column here. And it talks about some of the information that we just covered. So it just gives a quick snapshot, right? With Medicare Part A and B, your original Medicare, you can go to any doctor at any point in time as long as they are contracted with Medicare, and you can schedule that appointment with the doctor. With Medicare Advantage, you have to see your primary care physician first, and then that primary care physician that you have selected in that Medicare Advantage plan will then can refer you to another specialist within the network for you to go see. So with original Medicare, you don't need a referral, but with Medicare Advantage, you do need a referral to be able to see a specialist. And there are, again, some cost differences as well. With your original Medicare, the patient has to be responsible for the 20%. But as we discussed, if a patient obtains that supplemental Medigap plan, that Medigap supplemental plan will cover that 20% that Medicare allows. There's premium amounts that you have to pay with the original Medicare, whereas with Medicare Advantage, there's either no premium assigned or it's a very small amount.
Okay, let me chime in just a bit.
Of course.
Historically, the reason Medicare Part C was developed is because the federal government wanted to save money. So they agreed to pay 95% on average of what they would pay, that they had figured out for a certain kind of population that would cost Medicare 100%. They would pay these plans 95%. The idea being that the plans would be more efficient. Because these plans are privately run, you need to understand that you are no longer in the public sector, you are back in the private sector. And over the course of time, the Medicare private carriers, quote Advantage, have managed to extract from the government the equivalent of about 111 to 114% of what they would pay in original Medicare, which is what allows them to offer things like lower premiums and the perhaps eyeglasses, etc., which are typically low cost. The other thing you need to understand is that with original Medicare, you have freedom of choice. You can go to any doctor, any hospital, any laboratory, any X-ray facility you choose. With a private plan, you are now going to play by their rules, which are different. And as Shireen said, you can take your nice red, white, and blue Medicare card and stick it in the drawer. So you just need to weigh things in terms of A, what you think you want, what your values are, and what you think your out-of-pocket expenses are likely to be, realizing that the reason to have insurance is because you don't always know what to expect. Rolling along.
Thank you. So we've reached our appendix. I'm not going to go into great detail. These slides will be available for you as resources. So this is these are some areas for the supplemental coverage that I mentioned. You want to call your state insurance department if you have any questions. Here's some other links to Medicare, or you can call the Medicare helpline, and they can definitely help you if you have questions about the Medigap type coverage. Some additional resources, your Social Security Administration will talk specifically about Medicare. This link here gives you a information brochure about your welcome to Medicare. So for first-time patients when they enroll into Medicare, as well as Medicare and You is also another document that will be extremely helpful. It goes into a lot of detail of the information that we covered, a lot more detail of the information that we covered today. And then the next couple of slides you can take a look at. I have some definitions of what we talked about, your premiums, your out-of-pocket amounts, co-pays, that type of thing. So we'll let you take a look at that at leisure. And that's the end of today's presentation. I want to thank everyone for your time and attention. We appreciate you being here. And Harley, I'm going to stop